Here's our slides, great. So this is my cornea case presentation. It's a case of mystery edema. I have a 61-year-old patient who's an otherwise healthy Caucasian pediatric intensive care unit nurse. She has a history of chronic anterior granulomatous uveitis of the left eye starting in 2001, about 17 years before she became my patient. She had KPs, sectoral corneal edema by history, a slow development of corneal haze over years, reported recent episode of dendritiform keratitis by the referring doctor. She had had negative systemic workup for things such as RPR, PPD, chest X-ray, ESR, CRP, HLA-B27, and ANA, all negative. Her flare-ups were every 3 to 4 months and were treated with topical steroids and oral Valtrex or acyclovir. And she underwent cataract surgery in 2008 for a PSC cataract that was likely secondary to all the steroid use. She had depot steroid administered at the time of that cataract surgery and reports an increased rate of flare-ups in the years following the cataract surgery. She also had an increase in intraocular pressure in the left eye, and it was either due to all the inflammation or secondary to steroid response. On presentation to my clinic, this is how she looked. She had uncorrected vision in the right eye, 20/20, entirely normal exam. Left eye, best corrected, 2400. Corneal edema with scattered endothelial pigment. She had bullae, greatest in the temporal cornea, central corneal thickness 684. It's a very hazy view of the iris and the anterior chamber, but was grossly quiet. She was on prednisolone or Durezol every 2 hours over the last 4 months prior to presentation in my clinic, and she was also on Valtrex 1 gram 3 times a day for those last 4 months. This was a presumed herpetic keratouveitis with endotheliitis, and now with an endothelial failure and bullous keratopathy. So the next steps, she was very motivated to avoid surgery, so she wanted to try anything first. So we started with hypertonic drops and ointment, started famciclovir in case it was resistant HSV to the acyclovir and Valtrex, started topical preservative-free dexamethasone, and sent serum virologies, which were not helpful. The IgG was positive for HSV1, VZV, EBV, and CMV. That was serum, so indicating prior chronic infections in the past. Negative only for HSV2. We were unable to obtain speculars of the left eye due to the edema. It was entirely normal in the right eye. And she developed worsening edema over this time with painful bullae, and her vision dropped to count fingers, so she was now less motivated to avoid surgery. So first off, if you want to use the audience response system, what's the diagnosis? Is this PBK from her cataract surgery in 2008, endothelial failure from herpetic keratouveitis, failure from idiopathic uveitis, or failure from another cause? So we haven't nailed the diagnosis yet. And it's the results are favoring endo failure from herpetic keratouveitis pretty strongly. And so at this point, the treatment, let's back up there we go. Periocular depot steroid, a steroid-sparing systemic therapy, DMEC or DSAIC. Go ahead and vote on that. And a few seconds left there. Okay, and of course, being a DMEC session, I think the answer is obviously with the 2/3 going for DMEC. So I proceeded with a DMEC surgery using our preloaded S-stamped, pre-stained tissue from the eye bank. Went with an 8mm graft. It was a challenging view, but I was able to leave the epithelium intact. And I was worried about that because this history of dendritiform keratitis, I didn't want to have a big epidefect that might create more problems. At the time of the surgery, I did an aqueous sample for viral PCR for HSV, VZV, and CMV. Interestingly, I found the intraocular lens to be a one-piece SN60 that was unstable. The edge of the IOL was prolapsing forward when I shallowed the chamber, and it was possibly in the sulcus. I was unable to tell and too chicken to look further. So on post-op day 5, she was already improving dramatically. She went from count fingers to 20/50. Cornea was clearing nicely, bubble was above the pupil. Graft was fully attached, but I could now see iris transillumination defects evident, and so I did a gentle UBM because I was curious about the position of this lens. The superior iris was clearly contacting the optic, and there was an abnormal insertion of the iris, abnormal insertion angle that you can see on the UBM here that kind of complicates the picture a little bit. We were unable to fully visualize the superior haptic. On these pictures, you can see this iris chafing, these TIDs. It perfectly corresponds to the optic edge, and the optic edge also has pigment on it right in this area. This is undilated and dilated. So later on post-op day 5, got some more interesting news. The aqueous PCR came back CMV positive with a quant of about 15,000. HSV and VZV negative. So I started ganciclovir gel, 0.15% concentration, that's a commercially available product, 5 times daily, and did my normal prednisolone 6 times a day for a week, and then 4 times a day. So now our working diagnosis is that she actually had CMV endotheliitis with an anterior segment inflammation, followed by steroid-induced cataract. Then after cataract surgery, now with a possible partial UGG syndrome from an exposed optic edge and CMV endotheliitis as well. So further management for this patient, would you do a lens exchange, continue the topical ganciclovir and steroid and see how she does since her vision's improving, or oral ganciclovir and topical steroid, or steroids alone and no antiviral? And our voting is in. Oral ganciclovir had a strong preference there. So I consulted with some folks from Australia and the Singapore National Eye Center to try to get a little more information because this is not a diagnosis I see often in the States. And they said since her quant was fairly low that we could continue with topical and look for more flare-ups. So we tapered her steroids as quickly as possible to BID FML, continued the ganciclovir topical at 3 times a day, and less than 3 times a day can contribute to resistance, so it's best not to go below 3 times a day. And if she has a repeat of inflammation, we plan to do an anterior chamber tap. And if the tap is negative, but she's having inflammation and pigment release, then I'll plan to do an IOL exchange. Otherwise, I'm just going to watch that as a red herring. But this is how nice and compact and clear her cornea is now from her count fingers initially. And at post-op month 6, uncorrected vision 2025, clear and compact without edema. She has mild haze from her long-standing edema. Central corneal thickness went to 449 from 684, and her cell loss is currently at 28%. So corneal endotheliitis was first reported as an autoimmune disease in 1982 by Kudetust. HSV was later detected and implicated, but it was still often idiopathic. 2006, koizumianol implicated CMV as the causative agent in many of these cases. It's still relatively rare, most commonly reported in Asian populations. It's associated with ocular hypertension and glaucoma, and associated with very poor graft survival in many series. The Japanese corneal endotheliitis study group defined the diagnostic criteria, which included aqueous PCR that was positive for CMV and negative for HSV and VZV, along with clinical findings of endotheliitis, including as coin-shaped or linear KPs with sectoral or corneal edema, and 2 or 3 of the following, such as a recurrent chronic uveitis, ocular hypertension or secondary glaucoma, and corneal endothelial cell loss. And my patient had absolutely all of these findings. So management of CMV endotheliitis, the diagnosis really requires a lot of clinical suspicion. But now anytime I see a hypertensive uveitis, especially with a history of sectoral edema and a poor response to steroids and no response to acyclovir, or repeated graft failures, I'm going to obtain that anterior chamber tap, at least at the time of EK, if not prior to. There are absolutely no randomized clinical trials to guide our therapeutic decisions. There is a good paper that shows that systemic ganciclovir or topical ganciclovir can be helpful, but you do have to watch for myelosuppression and neutropenia with systemic. The best reported results are from Kitazawa and Kinoshida's paper. They did the stake in 6 eyes of 6 patients and had preoperative and perioperative systemic ganciclovir because they had the diagnosis before surgery. And then they used a compounded 0.5% topical indefinitely. And they have by far the best results reported and that all 6 grafts were surviving at a mean follow-up of 40 months and a range of 12 to 60 months at the time of their paper. Thank you very much for your attention.